Guys, at this year's VEITH meeting here in New York, we had the most interesting session on the treatment, diagnostics, as well as the prognosis of patients with type B aortic dissection. In particular, with focus on studies at this stage and the need for potential further studies in the near future.
That's right, Christoph. I think we've all learned over the years that we shouldn't adopt new therapies when possible unless we have randomized trial evidence to base it on. And we talked about the trials that have been done for endovascular repair for type B aortic dissection being the Absorb and Instead XL trials, and that both of those trials were negative, did not show benefit from endovascular repair, and so that we need to proceed to a larger trial to see if this is the best treatment.
Well, the Instead trial, as you all know, was basically a pilot to show that in addition to medical management, which was surprisingly well perceived and did a good job in perceiving and preserving survival up to 94%. The endovascular scaffolding, the stent, in addition to medical management, was helpful in order to basically set the stage for remodeling. And eventually, as the extension of Instead showed, helped to stabilize the aorta and prevent late rupture, late complication. In that sense, the XL, the extension of the actual 2-year follow-up, showed that the initial investment showed benefit long term.
So guys, you disagree, I think, on whether the trial was positive or negative. So Frank, your point is that the primary outcome measure of all-cause mortality wasn't met, and I think, Christoph, you'd say that in terms of aortic-related mortality, the endovascular repair actually conferred some benefit. So to give you a sort of view from my perspective, the bit that concerns me the most, if you like, out of both Instead XL and subsequently the IRAD data, is that the prescription for our patients who we don't treat with endovascular repair at the moment is best medical therapy and surveillance. And it strikes me from the trial data and also the IRAD data that best medical therapy, CT surveillance and intervention is not preventing aortic-related death. And so I wonder how we all feel about randomizing, if we're going to do further trials, patients to best medical therapy when it seems not to be fulfilling the aim of aortic-related death. And for me, that's why I think I'd be hesitant about a further randomized trial. I think we need more information, but I wonder whether the design is not randomization.
That's right. That's right, Matt. We believe that we could show something in addition to just medical management. Whether the next step or the next big trial would be a trial under a randomized format is questionable. I think personally about a strategy using basically registry data and randomizing within that registry into 2 different treatment strategies. That, of course, leave it open for a patient to be randomized in one end, let's say in medical management, then later on crossover because of lurking complications, late complications, and so on. But I think the trick to gather data in a big quantity is to use registry formats rather than randomized trials, which are, by the way, extremely expensive these days.
I would just caution that we've learned over many studies over the years that when the primary outcome is not positive, as was the case in the Instead trial, was not positive, it's easy to find a secondary outcome or a way to perceive a trial as positive, and those results often mislead us when we do look at another trial. So I think currently most of the recommendations are for medical management. We have an indication that endovascular repair might be a way forward, and that's when you want to do the big trial and make sure that you really are getting the results you want. It's difficult to know whether a lot of deaths are aorta related or not, and unless you have I think the primary outcome in the trial that Chris led was appropriately all-cause mortality, because that's the most important outcome. That's the one you know. And I think until we have a larger trial that shows that, it remains sort of dealer's choice as to whether you use the medical management or the early endovascular repair.
Well, I think we all agree that another bigger trial with an appropriately chosen endpoint is necessary, that needs to be met or needs to be explored further. Matt, what do you think? In the meantime, should we limit the inclusion window to a certain
I think some of the issues that will need to be fleshed out with this is actually we're talking about a relatively small proportion of patients who undergo TEVAR for this particular indication. We're all, I think, comfortable with TEVAR for complicated dissection, and I have some hesitancies about whether we would be able to recruit sufficient patients in a large randomised manner to actually address some of the issues that need to come out of the trial. And in particular, I think we'd all be keen to understand which subsets of patients derive the most benefit from endovascular repair and which subsets of patients perhaps it would be inappropriate to offer endovascular intervention. And my slight hesitancy is that to achieve those subgroup analyses we need a very big trial. I wonder whether there is the equipoise in the community and actually the number of patients to generate the sort of large database that we will need to address those endpoints. Finally, I guess we always come up, Frank, with this issue about what's the most appropriate endpoint in aortic trials, and I think we've addressed it in the EVAR trials, and it's come through the INSTEAD trial as to whether we should be looking at all-cause mortality or whether we should be trying to dissect out aortic-related mortality, because of course what we're trying to do by putting an endograft in is prevent aortic-related death. We're not trying to prevent death from other cardiovascular causes and cancer, and I think that's always been one of the tensions.
I completely agree, Matt. That's the difficulty. What we're interested in is the aortic-related death, we think. Although when you do a procedure, other deaths can come up later that are not as easily identified. But so many deaths, people who work with death certificate data know, are completely unresolvable. And so when you depend on that, it's difficult to generate reliable data.
Don't you both agree that the later we start such a big trial, the lower the percentage of equipoise will be in the community?
I think that if you review the evidence that's available and make the case, most people, and the trial starts, most people will usually see their way to participate. The problem is this is not such a common disease, and the number of patients in question here is, as Matt points out, somewhat limited, that it would be very challenging. It would require a multinational trial. There's a lot of regulatory issues, and this will not be an easy trial to do. Chris and I have also proposed a trial of the currently recommended intensive medical therapy versus more ordinary management of blood pressure, and the two trials could be done together, but both face the same problem of how do you find enough sites and places willing to participate to really get the answers we need.
Yeah, so I think we're fraught with difficulties in a big randomised study. Personally, I think we're probably going to need to have a very clear look at whether a prospective cohort registry, perhaps with randomisation within it, using that sort of methodology, is appropriate. I think the patient recruitment will be a problem, and actually I think with new data on subgroup analysis there will be less and less equipoise. So if we start looking at aortic morphology with big entry tears, perhaps patients who've got multiple fenestrations, who've got positive inflammation on PET-CT scans, we're going to find physicians are actually taking those subgroups of patients and refusing to randomise them, and that, I think, is my problem from a pragmatic perspective of how we're going to get the numbers that we might need.
That's exactly the case. We're already collecting more and more silent complications on that list of complications for a given patient, and we all agree and feel relatively comfortable with the idea to treat actively those patients that qualify as complicated dissection. So in other words, it's getting more and more difficult, and the sooner we start, the greater the chance we actually can collect such an amount of data.
My experience has been once you put a good protocol together, that's always a concern, that people already think they know how they want to practice, but they also know they don't have randomized data, and once the protocol is put together and the trial moves forward, we have found very few physicians refuse to participate because they think the equipoise is not met. If they have a question, they look at the protocol, review the data that we've reviewed, and often come to the same conclusion that we still have a big question here, and this is the one opportunity to answer it, and they usually want to be part of that answer.
So I think we have two potential near future trials. One is on intensified medical management of patients with type B dissection, and the other one would be with a global mortality endpoint, comparing medical management as well as medical management in addition to a stent graft in so-called stable or non-complicated aortic dissection. That is the so-called INTEC trial, to be started next year.
And one modification you can make to make it more doable is to exclude the cancer mortality, which is more easily identifiable from death certificate records than any other kind, and that's a third of the mortality and cuts your dilution by half, so you can focus in more on what you're interested in.
Excellent point.